Recording in progress.
Okay, so very good evening, everyone. I'm Dr. Supriya, the current medical lead at the Gennova. It's my absolute pleasure to welcome you all today to today's national workshop known as No Thrombosis. We all know that stroke continues to be a major contributor, to the related morbidity and mortality. And today's session basically focuses on real case insights through the case-based discussion. So with that, I just want to introduce our first course director for today's session. We have Dr. Subhash Kaul sir with us. A brief introduction about sir. Sir is a senior consultant at Department of Neurology at KIMS Hospital. He is a highly skilled neurologist with more than 40 years of experience in the medical field. Sir has 105 publications to his name and has contributed to more than 20 chapters. He has delivered more than 300 lectures, including orations in last 25 years. Sir also has been a principal investigator to various clinical trials, national, international, and also the one which are ICMR funded. Sir is also an expert reviewer and member of editorial board of different journals. He has almost more than 30 years of teaching experience in neurology and has trained more than 50 students in DM neurology. Sir has also a lot of awards and accolades to his name. To name a few of them, they are State Teacher Award by Government of Telangana. He's also been a past president of Indian Academy of Neurology, Indian Stroke Association, and Andhra Pradesh Neurology Association. Sure, sir also has done his fellowship from the Jacob Javits Stroke, which is from the University of Maryland, Baltimore, USA. He has done a fellowship from the FAHA and also from FAN and FRCB. We welcome you, sir.
Thank you.
Moving on, for today's session, we have our moderator, Dr. Praveen Kumar Yada, sir. Sir is a consultant neurologist at KIMS Hospital. Sir has finished his MBBS from Orissa, his MD General Medicine from Osmania Medical College, and his DM Neurology from, again, Nizam Institute of Medical Science from Hyderabad. Sir has presented a lot of papers, posters, and in the conferences like APNSA 2 2011, Econ Hyderabad, API 2006, Guntur, and CONI Bangalore 2012. Sir is also a co-author at the chapter of Tropical Neurology, and he's also a member of IAN and ISA. We welcome you, sir.
Thank you.
Moving on, our first speaker, we have Dr. Chakradhar Reddy, sir. Sir has done his MBBS DM Neurology and also a fellowship in movement disorders. Sir is a consultant neurologist specializing in Parkinson's disease and movement disorders with almost more than 8 years of clinical experience. He has expertise in advanced management of movement disorders, which includes tremor, dystonia, and Parkinson's disease. He has completed his postdoctoral fellowship in Parkinson's and movement disorder 2023 in neurology from NIMHANS. He is recipient of Young Investigator Award at the World Stroke Congress, Montreal in the year 2018. He is actively involved in clinical research and academic publications in neurology and movement disorder. Sir has published a lot of work in reputed journals focusing on deep brain stimulation, oculomotor dysfunction, neuro-COVID, and neuroimmunology. Sir has also contributed to advancing diagnostic precision and therapeutic outcome in complex neurological disorder. We welcome you, sir.
Thank you.
Moving on to our second and last speaker, we have Dr. Amreen ma'am. She is currently working as an assistant professor neurology in Singrani Institute of Medical Science, Ramagundam, and a Krishna Neurospecialty Hospital at Goda Varikani. She is also actively involved in comprehensive neurological care and teaching. She's expertise in acute stroke management and neurocritical care. Ma'am is skilled in managing epilepsy, headache disorders, and head injuries. She's experienced in treating spinal cord and peripheral nerve disorders, and she has a very strong focus on evidence-based clinical practice and patient-centered care. We welcome you on. So with that now, thank you. So with that, now I would hand over the session to Dr. Subhash Kaul, sir, to set up the context for our today's session. Over to you, sir.
So thank you, Supriya, for that brief overview of the whole program and the speakers and moderators. And, one of the peculiar features about stroke is that we have to constantly think on our feet. In other diseases, we can think at leisure. We can think today, then go to library, then check our facts, then discuss with our friends, our teachers, and take a decision after 2 days, 3 days, 4 days, 1 week. It doesn't matter, But in stroke, every second counts and we have to think on our feet. And in this way, it's a race against time. And we cannot afford to be anything but perfect because it's patient's life. I mean, a patient of stroke is like a house on fire. If you wait, the whole house will be burnt, and it becomes very challenging. And each stroke is different, as we see. Even after a lot of experience, we commit judgment errors, we commit mistakes, and even though we talk of clinical trials, those trials is a aggregate of thousands of patients. But the patients don't come to us as an aggregate of thousands of patients. Patients come individually as each single patient to whom the clinical trial data may not even apply. So these forums are very important, forums like this, which are case-based, because here we see the spectrum of the clinical features, the challenges. It's a spectrum, it's a huge spectrum. And each patient may be different from the other patient. So with that, I welcome all the participants of today's program, and it's my pleasure to invite Dr. Praveen Yada, who is an excellent stroke specialist himself. I almost consult him very frequently, and he will coordinate. Praveen, I'll request you to invite the speakers one by one and keep count of time also. I think we have to finish at 9 o'clock. So maybe after each case, we'll have a brief discussion and we'll round up before 9 o'clock. Dr. Praveen, as already introduced, Dr. Praveen is a very famous, successful neurologist at KIMS Hospital, Secunderabad. Dr. Praveen.
Yeah. Thank you, sir. Uh, for the first talk, I will invite Dr. Chakradhar. Sir, if possible, we'll start the presentation as early as possible.
Yes, sir. We can start this. Thank you, sir.
Yeah.
Kalpita, I would now request you to please share the slides.
We have Dr. Chandrakar going first, right?
Yes.
Yes.
Okay.
Okay. Shall I start? No.
Yes, sir.
Yeah. At the outset, I would like to thank Subha sir and Praveen sir for giving me the opportunity and to meet the eminent neurologist. Just I'll be discussing two brief case scenarios which we encountered and how we treated it, and wanted to learn more about this from our chairpersons. So going into the topic, this is tirofiban as a versatile antiplatelet usage in acute ischemic strokes. As there is growing evidence in this aspect using tirofiban, I just wanted to share this knowledge. So I'll be discussing initially two case scenarios and a brief introduction regarding the pharmacokinetics of tirofiban and what is the current evidence and published literature over this. Yeah, next time. Coming to the case one, they had a young female. She was 28 years and was a known case of SLE, which was very well controlled without any secondary organ damage. She was just on a very small dose of omnocotril for 2 years, and our rheumatologist, she was following up, and she was on immunomodulator, was also HCQ. She was taking. She presented to us with the right hemiparesis of 3 hours duration. Predominantly, I'll be discussing. There was a history of intermittent brief period of right lower limb weakness. From past 5 days, she had 3 such episodes before she was presented to our emergency department. At presentation, she had an NIHS of 5. During the examination, she had right upper limb of 3/5 power, and lower limb it was 2/5 power. lower limb was little more affected than the upper limb. And since it was a within window period stroke, we immediately activated our stroke team and got an next slide. We here at our hospital, we do a brief MRI, including the diffusion and flare and the top image, followed by a CT, angio and perfusion studies. And so she underwent this. Here we can see the diffusion weighted images showing the medial frontal and parasagittal region, diffusion restriction, acute diffusion restriction, with no significant flare changes as of now, suggesting an acute evolving stroke. And the staff did not show any, even the angio also we have done, I can put the images. There was no major vessel occlusion and the perfusion deficit was also not significant. We suggested a small vessel acute stroke. Then actually what happened is, as till this time, we had a regular case type of, but once the scan was done and being shifted to back to the ER, she had improved again spontaneously itself. This scan time took about 30 minutes. So when we examined again, her NHS came down to 0. Literally, she was completely normal as before. So since the NHS is 0 and she did not qualify for thrombolysis, we deferred this. And since she had fluctuating course and possibility of recurring of the infarct again and deficit, we thought we would, since the literature I could have studied recently, and initially we tried in few patients, we considered a tirofiban infusion because of its certain properties which I'll be discussing. And she was initiated on this and we continued it for 48 hours of infusion. After on the previous slide, so our other workup to rule out any was it a cardioembolic stroke or any APLA workup was also done, and it was a negative. And over the third day, she was discharged. After starting tirofiban and till the discharge, she did not have any new deficit, and NHS was 0 and MRS was 0 at discharge. And even she came for follow-up after 3 weeks. There was no deficit at all. We were managing with antiplatelet echospin after that. Yeah, next slide. This was one case scenario where we did not spontaneous improvement, and we went on with monotherapy, initial therapy of tirofiban. Now the second case is she was also a young lady, 30 years, without any comorbids. She presented with 1 hour duration of right hemiplegia, and it was dense hemiplegia with NIHs of 13 and right upper limb and lower limb powers were 0. Yeah, next slide. So since within window, again we have done a stroke protocol imaging. Here we can see the putaminal and posterior limb of internal capsule diffusion changes and medial periventricular changes as well, without any significant flare changes, suggesting an acute infarct. In similar way, this case also did not had any major vessel occlusion, and there was no major perfusion deficit. Yeah, next slide. Next slide. So in this case, she had persisting weakness. Then we had thrombolized with the tenecteplase 15 milligrams. Our door to needle time was 1 hour. Post thrombolysis, after 30 minutes, she showed improvement. At 30 minutes, her NIHS was 5, and the right upper limb power from 0 to it improved to 4, as well as lower limb also the same. Then she was admitted to the ICU for monitoring over a period. After 3 hours, again we received a call that she had deterioration in power and she was not able to lift her hand again. That time, almost 3 hours after the thrombolysis, then NIHS was 9, and from 4 again the upper limb and lower limb power deteriorated to 1. We thought we need to rule out obviously bleed, so we did a CT scan and bleed was ruled out. Then we considered it as early fluctuations and possibly because of the reocclusion phenomena. And in this case also, we went on with tirofiban infusion was started and continued for the next 48 hours. post-tirofiban infusion, after initiating this, within around 8 hours later, that is in the next day morning, her neurological deficits improved, and it was just an HS2 with upper limb power was normal, lower limb was just 4/5, and mild dysarthria was there. And on day 5, we discharged her without any deficit, with NHS0 and MRS0. So these two case scenarios, I would like to highlight that one had spontaneous improvement, one has deterioration post thrombolysis. In the so regarding the tirofiban multimodality usage in this, because of it is a non-peptide one with a GP2B and 3A receptor antagonist, which inhibits the binding of fibrinogen to the platelets. In addition to that, it also in rat models and all, they have also documented that it has an anti-inflammatory and antioxidant effects in addition to the antiplatelets, which would also prevent the further secondary neuronal damage in acute ischemic strokes. So this has an added benefit in comparison to our routine available oral antiplatelets. The other main effect which comes into play is its onset of action is within 5 minutes, and half-life being 2 to 2 hours. And the effect of antiplatelet effect fades out within 4 hours after discontinuation. So these properties, pharmacokinetic properties, make it more user-friendly and effective early to reduce the early deteriorations and the reocclusions. So, and also it is eliminated predominantly through renal and to a certain extent even hepatic pathways. Yeah, next slide. So here I would like to, so for available data I'll be sharing regarding tirofiban usage as a monotherapy, as a primary immediate without any reperfusion therapies. In case of early neurological deterioration is post acute ischemic stroke is reported in about somewhere between 50 to 40%. And most of them occur within 24 hours of the onset. So it's early management of this would have an impact on the recovery of the patient. Delayed antiplatelets action may contribute to less recovery of this patient. That may be one of the factor where tirofiban, because of its rapid onset of action, will be beneficial. And this was evident from a trend trial, which was recently last 2024, it was published. Here, almost about, they have tried patients in acute ischemic stroke. In comparison to the aspirin, they have given initially for 72 hours, two groups, one group with tirofiban and the other group with aspirin. And post 72 hours, they have assessed early neurological deterioration in each group. So where tirofiban has performed significantly better with low early deteriorations in this trial. And there was also a meta-analysis performed using the major RCT trials. 4 trials were included. For the analysis, most of the analysis, 90-day outcome was measured in this meta-analysis. And together about 1,199 patients were included in all these 4 RCTs regarding the tirofiban usage as an initial monotherapy. Yeah, next slide. Next slide. Yeah. This is the previous one, efficacy. Yeah. This was the forest plot of the meta-analysis data. As in this, 3 studies were analyzed because the 90-day outcome was not provided in the one study. Here we can see only the MRS 0 to 1 excellent outcome at 90 days favored tirofiban in comparison to the control group. And even the MRS, a good outcome, which they took it as an MRS from 0 to 2, also showed that tirofiban had significant benefit over the other arm. Yeah, next one. Next slide. This was regarding the efficacy data, whereas, go to this. Yeah, in this safety data also, here they have included all the 4 trials, cities. Here we can see that tirofiban is associated with more chances of spontaneous ICH as well as in the spontaneous ICH it is more, whereas in any sort of ICH it is same. However, in both these cases, it was the significance was not there, but there was a tendency of high number of bleeds in case of tirofiban group. Yeah, next slide. So from this meta-analysis, they have suggested that tirofiban is associated with significantly higher rates of excellent and good outcome measures at 90 days compared to the oral antiplatelets. However, in the safety profile, there is slightly increased risk of symptomatic ICH as well as any ICH, but without any significant difference between the control group. Yeah, next slide. And data regarding the second case where post-thrombolysis, reocclusion and deterioration, there is also some evidence that tirofiban as an adjunctive therapy. Here we have predominantly one trial has published the results where asset IP trial. Here in this, along with the tirofiban and a placebo group was compared, where each group had a significant proper number of 400 patients in each group, near about, who underwent thrombolysis, and but they did not undergo any intervention. Yeah, next slide. This was the baseline characters. Here we can see some of them were mostly from the large artery atherosclerotic diseases, and some were from small artery diseases as well as undetermined. And most of them were altiplase was used for thrombo. Hello, yes, sir.
Please go on, sir. Please go on.
Okay. And tenecteplase was used in few. In these patients, post thrombolysis, the mean time, previous slide, please. Mean time of giving starting of tirofiban post thrombolysis was in both the groups almost within 44 minutes. They have started the tirofiban. In this, you can see median duration in the minutes when they have started the tirofiban infusion post thrombolysis. Yeah, next slide. These are the outcome charts. Primary outcome, once again, it was MRS from 0 to 1. As we can see, there was a significant outcome benefit in tirofiban patients, particularly those who are without any deficit. They have improved about 65%, whereas in this case, it was around 55% in placebo group. Coming to the intracranial hemorrhage part, the side effect profile part, symptomatic ICH as well as asymptomatic ICH, both were more in tirofiban group, but however, this was not significant when compared to the placebo group. Yeah, next slide. So inference from this RCT was in patients with mild to moderate non-cardioembolic ischemic stroke patients who were not scheduled for any thrombectomy and were treated with IV thrombolysis. Tirofiban administration within 1 hour of completion of thrombolysis resulted in better functional outcome at 90 days than a placebo group. With it has a slightly increased risk of symptomatic ICH in the background. And all these trials did not take up the cardioembolic stroke. The reason they suggested was cardioembolic strokes are more fibrin rich when compared to the atherosclerotic, which were more of anti-platelet rich. So tirofiban was more beneficial in atherothrombotic form of acute ischemic strokes. That was the reason. So in none of these trials, all the trials ruled excluded the patients with cardioembolic strokes. Yeah, next slide. Yeah, coming to the end. So tirofiban has a multi-purpose role as a monotherapy, as an adjuvant therapy, because of its pharmacological properties, and because of favorable pharmacological properties like rapid onset of action is the one of the interesting feature in this, with early reversibility of antiplatelet effects when in case of any side effect also, and proven efficacy in early phase of acute ischemic stroke patients who were ineligible for reperfusion therapies, and as an adjuvant therapy in those with early reocclusion. However, caution to be taken regarding the bleeding risk, which is comparable to the current oral antiplatelets. That's all. Thank you, sir.
Yeah, wonderful, wonderful. As Kalsar always says, we learn stroke case by case, and always the problem of reocclusion after stroke that exists, and that's a challenge. We have not been we have not been able to explain that, and possibly the use of tirofiban as it increases, it comes into the picture. Unfortunately, till now, even in the recent update in the Jan 2026, tirofiban has not yet come into the guidelines. Therefore,
mentioned
yeah.
it as a 2B result, 2B recommendation they have given, sir.
Yeah, therefore, for call, sir, if we can't use it, therefore we have to use it with lots of caution. Is it? How should we use it in a patient, as is the Dr. Chakradar's case of second case after thrombolysis patient having a weakness? That's a big problem. Normally, we read that we practice that after giving alteplase or tenecteplase, we don't touch the patient for 24 hours. But as rightly showed by the RCT, there are many places, many doctors also, after giving tenecteplase after 1 hour or so, they repeat the scan. If the scan is good, they even start antiplatelets. That's the practice many follow, but they are not yet in the guidelines. Therefore, for general purpose, we have to be very careful. And such cases, the caveat being that there can be, once there is a bleed, that becomes a problem. Therefore, after explaining everything and taking a proper consent only, we should use tirofiban. As of now, indications that, as you suggested, in the ICAD or in reocclusions, especially during mechanical thrombectomy, or if you are planning for a stenting, it has been suggested. But I think so we need more data before we use it as other antiplatelet agents.
Yeah, no, first of all, Dr. Chakradhar, I think it's a good presentation. I think thank you very much for sharing your experience. It's a new compound, new molecule for us also. I have also used in a limited way. But I have some queries. First is that the literature which you surveyed, in that what has been, for how many days it has been given, this infusion? What is their protocol?
Yeah. 3 studies have given it for 24 hours, sir. One study, that whatever the asset before the trend trial, has given for 72 hours also.
Okay. So up to 3 days it has been given.
Yeah.
But not beyond 3 days.
No, beyond 3 days. Most of the trials 24 hours, and 2 trials, that asset IT has given 48 hours. The highest was.
And second thing is that as far as 2026 guidelines is concerned, where does it feature? Under which heading it features? I mean, do they say we should give it after TPA? I mean, where does it come in? Under which heading it comes in 2020? Because I have not seen, that's why I'm asking.
Yeah, they have given it in the 2B under antiplatelet usage 4.8, sir.
In acute ischemic stroke, right?
Acute ischemic stroke only. They gave it as that.
Okay.
Acute
I think
ischemic
I will have to. I mean, do you have guidelines in front of you? Can you read that if at all it's
I'm
in
just
front of you?
scrolling down the, sir.
Yeah.
I'll just.
So we want to see how it has been phrased, because that will help us in using it.
Yeah. In the box, they have just a second.
2B is fair enough. 2B means that we can take a decision. We are allowed to take a decision.
Endovascular therapies. Let me.
Now, in the meantime, till you see, I was first introduced to this during the when I surveyed the treatment of the capsular warning syndrome.
Okay.
You know, when patients having 40 TIAs, 50 TIAs. So in that, this was some trials had shown that it's not better, but it's as good as heparin or TPA and all that thing. So that was one. But recently I'm seeing, then after that we saw that it was being used for, by interventionalists often use it. When something goes wrong while they are doing intervention, then suddenly they start tirofiban infusion for 24 hours. But recently, then once that NEGM study came, no, that it got a lot of importance, that after TPA you can give it. And I had personal interaction with some doctors who have given it after progressing strokes, progressing lacunar strokes, or even large artery strokes, and they were having good opinion. I also recently gave to one patient of ICAD, and some of the attacks were stopped. But I mean, I have not studied guidelines so closely, but superficially, I couldn't see it in the guidelines, because if it's in guidelines, then it's very nice. Then we are safe. Then we can give it. But the drug definitely looks to be promising. Everybody has got good opinion about it.
Yeah, I just wanted to know, sir, why was only the Chinese trials are more in this rather than the Western trials? I could not find any significant paper on this from Western data.
No, we cannot answer that question. No, how will we know?
I mean,
China is doing. You see, I have the one problem with Chinese trials is that people don't believe them. That is one problem. And China, even though it's a superpower, I mean, I'm talking publicly to you at this time, but a lot of people have reservations against Chinese trials. So,
I mean, a race-specific Asian people have more.
yeah,
Yes,
I know. But I think we should treat each trial respectively. But the problem with FDA is that it does not look at the Chinese trial in the same way, or any Oriental trial, even Japanese trial and all, as it looks at their own trials. So that's why silestazol and all these drugs they are not grade 1. In Japan, they are being used so much. So, but I think I think you have shared very excellent experience. I think it will in situations. I think we should definitely use it. When particularly the one which I have seen, you have shown in patients who are having recurrent events, and definitely for capsular warning syndrome and all, it has been shown. Even though it may not be in the guidelines, but it has been shown to be useful in trials. And what you have shown is recurrent events, right? But what I have also seen people talking about it is in progressing strokes.
Progression also the recommendation is
We have nothing for progressing strokes. And that progressing strokes happens in lacunar strokes very often. The patient comes with mild stroke, and by evening that 4 has dropped to 3, by evening it's 1, and you are just helpless, you can't do anything. And I have seen people using it, progressing strokes, and claiming that it helped them to. Very recently, I was in Mumbai and I had a talk with Dr. Darshan Doshi, who is a very eminent stroke specialist in Mumbai. He talked about 2-3 stroke patients of lacunar stroke, where the moment it was progressing, he gave it, and the progression stopped. And so it's a good drug. I think we'll watch it with a lot of interest, and I think we'll start giving it and see how it goes. Thank you very much, Dr. Chakradhar, for sharing your experience. Yeah.
Thank you. That's all adds to our armamentarium. Now we'll request Dr. Amreen to present her case. Dr. Amreen.
Good evening, sir. Good evening, Dr. Subhash Kaul, sir. Good evening, Dr. Praveen, sir, and Chakra Reddy, sir.
Yes.
This is my first presentation.
All the best.
Ma'am, you need to share. Hello?
Yes, can you please share my slide?
Yeah, sure.
Yeah, sir. Here I could find one. Just I'll repeat the sentence from the acute stroke guidelines, AHA
Yeah,
guidelines.
please.
Yeah, it was in the, it is in the 4.8 antiplatelet treatment box.
So if
Where
you don't mind, I'll share the guideline. I have it with me, so I think that will be easy for everyone.
yeah,
Just a minute.
Yeah, you can share on the screenshot.
Yeah. Can you see my screen?
1 second. Yeah.
It's
No.
mentioned here.
Yes.
Yes.
Go down. Go
Under
down.
antiplatelet,
Yeah, go
2B
down.
is
Go
the
down.
recommendation.
Go down. Go down. Down. Early secondary prevention. Go down. No. It's the same only. Just box is down.
One
Just
second.
little.
Yeah. This one, early prevention, right?
Early secondary
Ah,
prevention.
Here.
Yeah. 2B. Little more. Yeah. Here. Spring.
No, I have already highlighted here. It's
Highlighted
there.
there. Okay. Okay.
Yeah, it's right here. Tirofiban, yes. And it's here.
Yeah, in this both 2B, you can see, sir, in patients with acute ischemic strokes, the efficacy of IV tirofiban to improve clinical outcome is not well established. It's 2B. And also in post-IV thrombolysis, with or without mechanical thrombectomy, is uncertain, they gave.
No, which one? Sorry, I'm missing it again. Which one? Can you just show it with your, can you pointer move? In patients with acute who have received IVT, the risk of antiplatelet in the first 24 hours after IVT is uncertain. Use might be considered in the presence of concomitant condition. I know, but where is tirofiban in this?
No, in that it is not.
Or second, after this.
No.
Okay. Yeah, it says it's not well established, but 2B means that you may give it.
Yeah,
right? It's not, even
may.
though it's not well established, still you can give it. Yeah.
Yes.
It is not harmful, at least. It is you may give it. That's what is 2B. Yeah, got it. Thank you. Yeah. Okay, great.
Over to you, Kalpita. You can share the slides.
Praveen? Dr. Praveen?
Yes, sir.
And I'm addressing all the members in this. 2B recommendation is a real recommendation because this is the one where it asks doctor to take judgment to himself.
Okay.
He is telling you it's not harmful. You can do it. And 2D recommendation is such a recommendation where you are allowed to do it, but even if you don't do it, still it's okay. Because if you look at if you decipher this recommendation, 2B means benefit is equal to harm. So in a particular clinical context, you may use it, and in a particular context, you may not use it. Whereas that is not in 2A. 2A, you are recommended to use it. In 1, you have to use it. In C, you should not use it. But 2B is really which tests as a clinician. When we say shared decision making, that is 2B. And a lot of recommendations are 2B, where, we have to take our own judgment depending upon the overall scenario. Right? Is it right, Dr. Chakradhar?
Yes, sir.
Okay, go ahead.
Wonderful teaching, sir. Wonderful.
Yeah. Go ahead.
Yes, sir.
Yes, Amarin.
Yes, sir. My slides have not been shared yet, sir.
Kalpita? Yeah, you can share it. Kalpita, am I audible?
Yeah, I have already shared it. Is it not visible yet?
It's not visible. Kalpita, maybe you can reshare again.
Yeah, is my screen visible now?
Not yet. It is blank.
Not yet, Kalpita.
I think now it is visible. It is showing your sharing your screen.
No.
Kalpita, you can double click to enter a full screen mode.
But you can share with me and share.
Yeah, I have already it's on the screen slideshow mode. Supriya ma'am.
Kalpita, we are not able to see.
Just a minute. Just a minute. Supriya ma'am, I'll share it with you or Abhijit sir. Just give me a moment.
Yes, I can see myself.
Yeah.
Is it visible now?
It is visible. Can you go to slide 3? Okay, thank you. Good evening, everyone. Thank you for giving me this opportunity. Delivering acute ischemic stroke in peripheral settings remains a significant challenge, especially when tertiary referral centers are located far away. Our center is located 250 kilometers from Hyderabad, and this is my 2-year journey. Reflects this transition of a single specialty center to evolve into stroke unit and deliver thrombolysis and facilitate thrombectomy. So, next slide. So, as my center is a single specialty operated center, there are a lot of challenges to face. Those are lack of awareness. Most of the people don't know the stroke symptoms, and even if they know, if the symptoms are very mild, they just ignore it and they go to local RMPs, and there they get treated either with BP medicines or some medicines, and they just sit at home. And another challenge is antiplatelets and heparin before reaching to our center. Most of the RMPs and even some general practitioners, they are administering antiplatelets and heparin even without scan before they reach us and within window period. So, and coming to counseling and cost is another hurdle. And regarding our center, we have CT and MRI, but CT angiogram is not available at our center. Next slide. So, after I joined here, my first case thrombolysis was on 7th April and on the 3rd day of my joining. And initially, before I came here, there were only hardly 4 or 5 cases thrombolized over 2-year duration. And after I joined here, I have dramatically increased it to 40 cases over my 2 years. Next slide. Next slide. So I'm presenting few cases. So a 38-year-old female with no prior comorbidities, she was brought with sudden onset of giddiness, vomitings, gait imbalance, and blurring of vision since 3 hours of duration. Initially, she went to a general practitioner. I don't know for what reason, she was advised MRI epilepsy protocol, and she got scan at our center. And again, after the scan, she was referred to a nearest higher center, which was 90 minutes away. She landed to our center, luckily, through an acquaintance. On examination, she had gait ataxia, nystagmus, dysarthria, and absent pulse in left radial, ulnar, and brachial artery. Next slide. Our diffusion showed diffusion restriction in left superior cerebellar hemisphere and left cerebellar hemisphere and left temporooccipital lobes. And this is post thrombolysis. This is evolution of the stroke, and we can see even the right superior cerebellar hemisphere also is involved, and left thalamus and dorsal pons was also involved. And she had occlusion in left PCA. Beyond P2, there was occlusion. Her window period was 240 minutes, and on her investigation showed the microcytic hypochromic anemia, and she was positive for ANA, and that was Smith and RMP was positive. She was later given, after thrombolysis, she was given anticoagulation therapy, and her MRS improved from 4 to 1. And this is her Doppler study. It's showing intraarterial thrombus in left from the origin of the axillary artery to it is extending to brachial, radial, and ulnar arteries. Next slide. Okay. Next slide. Okay. Another case, a 14-year-old boy. He was brought with sudden onset of weakness of his left side, and he had left ataxic hemiparalysis, dysarthria of 2 hours duration. And he had recurrent episodes of headache since 2 years. And I have thrombolized him. And his window periods were 4.5 hours. And he improved from NIHS 7 to 5. We can see his right capsuloganglionic region, left corona radiata, there is an acute infarct. And later I've evaluated him, and he was negative for ANA, APLA, LA. And coagulation profile was negative. Next slide. We have sent to other center to get his CT angio done, but it was inconclusive. It was reported as there was mild stenosis of M1 segment right side and probable thrombus or vasculitis. I have discussed with radiologist over there, but I was not convinced about vasculitis part because there was no contrast enhancement or no any bleeding appearance. Other vessels were all normal. So when this case was a challenge to me because I have not thrombolized a child. Like when I got this case, I have researched for data, and I have found some articles like we can thrombolize from children from 2 years of age. So I went ahead with thrombolysis. Luckily, and he improved. And he comes follow. He's coming for follow up, but now he is having some recurrent headaches. Next slide. So a 46-year-old male, he was chronic alcoholic smoker. He came with sudden onset of weakness of left side, unable to walk since 30 minutes duration. And he had similar complaints 2 years ago, but it improved within 2 days. And he did not underwent any medication for that. This is B2000 images, diffusion B2000 images. We can see faint hyperintensities in right hemipons. And post thrombolysis, second image is post thrombolysis. I have included this case because this window period was within 2 hours. I was able to thrombolize, and this was my best over this center. And NIHS is improved from 7 to 4, and vessels were normal. And but the backdrop was he was not willing for any evaluation of the stroke. Coming to next slide. Okay. So, a 80-year-old female, she was known diabetic hypertension. She was status post CABG. She was brought with sudden onset of dysarthria, right-sided weakness of 2 hours duration. Next slide. This image shows diffusion restriction over left frontal and parietal lobes in the left ICA watershed territory. And as we can see, the top images, actually there was right ICA, there was chronic occlusion, and left ICA there was absent flow because there was left carotid bulb, there was a fibrous plaque. It was causing severe stenosis, and it was extending into left proximal ICA. Next slide. So this case, we have post thrombolysis. Her power, she went walking. Her power improved significantly from NIHS 7 to 4. So my conclusion is in this 2 years experience, we have demonstrated that high quality acute ischemic stroke can be delivered in peripheral centers with timely imaging, rapid thrombolysis, and strong referral linkage, and clinical judgment is beyond rigid protocols. Next slide. Thank you.
Yeah, definitely, madam. I would like to definitely congratulate you because increasing the stroke the thrombolysis from 2 to 3 to 40 cases, that's great.
Thank you, sir.
And as you rightly suggested, after thrombolysis, if there is a chance that there is a need for thrombectomy, referral can be done and time is there. And one more thing about the pediatric stroke, it has now come into the guidelines. Therefore, the ASA 2026 first time talks about the pediatric thrombolysis. And as you rightly suggested, in a case by case basis. Yeah, that was wonderful. One point I would like to make, the young child with that has been well described, the arteriopathy beyond the M1, that is thought to be infection associated, especially in children, and big work has done even by Colser, isn't it, sir? Sir,
You're on mute, sir.
Yeah, you are right, Praveen. This is called focal cerebral arteriopathy, which is thought to be post-viral, and the way we think of so it can be following chickenpox, but it can be following any virus. That is the etiology in them. I just missed the first case. What was the summary of the first case?
First case, sir, she was 38-year-old female, sir. She was SLE. She had SLE. Sir.
SLE.
Yes,
Okay.
yeah, was there associate Takayasu, madam? Pulseless disease?
No, sir. Only left. It was because there was complete thrombosis of the vessel. Her pulse was not pulsing, but right side it was completely not.
So in the last case which you showed, you have actually gone to, you said 320 minutes, which means 5 hours and 20 minutes. You actually did that. The last case, what I read is 320 minutes, right?
Oh, sorry. It is typing mistakes, are probably 220 minutes.
It's 220.
Yes, sir. It was not definitely not outside of the window period. So not
Yeah, but even if it was 320, that was also okay, because these days now, of course, one has to do perfusion imaging to go beyond 4.5 hours, but now more and more people are saying that it is okay to give even up to 9 hours. And obviously, you can't do perfusion imaging in your center.
No, sir.
But so I was excited to see that it's 320 minutes, and I thought that probably you've gone ahead of us also.
Sorry, sir.
But even if so, see, even if you had done it, that would also not have been wrong. That's okay. But of course, you have to inform the patient and all. So I think I join Praveen in congratulating you. That is the final aim of thrombolysis, that it should be given wherever the patient is, at the nearest place, so that we don't waste any time. And I think that is so. So when there's a need for mechanical thrombectomy, there must be a challenge of cost also, because it's very expensive.
Sir, even thrombolysis is a challenge over here, sir. Cost of thrombolysis. So if there is thrombectomy, I have to fight with the patient.
Yeah. So but thrombolysis, they have to pay out of pocket, right?
Yes, sir.
IV thrombolysis. But thank God, tenecteplase is at least cheaper compared to the other TPA. This is cheaper compared to it. Yeah, that's very good. Praveen, anything else?
Yeah, just I wanted to add a point. When I first joined KIMS, I also had to have a problem that about awareness. But nowadays, patients do come and they first ask injection though, injection though, injection though. Therefore, as madam, you are increasing that, definitely after a few years, the patient will come and land with you and say injection though, injection though, injection though. Therefore, keep on going, madam. That's a wonderful journey you have started. Hope it keeps on evolving. Yeah, we had wonderful cases, wonderful 2 discussions.
Yes, thank you. Thank you.
Thank you.
Thank you. Now I would request Mr. Abhijit to please give the vote of thanks. Over to you, Abhijit.
Yeah, thanks, ma'am. So, with this, we would like to propose a vote of thanks. On behalf of Team Gennova, I would like to extend a very heartfelt thanks to respected Dr. Subhash Kaur sir for taking his precious time or being the course coordinator for today's KT Live. Also conveying our sincere appreciation and thanks to Dr. Praveen Yadav sir.
Thank you. Thank you.
And at the same time, also deep sense of gratitude to both our speakers, Dr. Chakradhar Reddy sir and Dr. Amin madam, for being the speakers for today's program. We are sure the delegates would have been immensely benefited by the wisdom shared by eminent faculty. So once again, thank you from behalf of Gennova.
Thank you.
Thank you.
Thank you, everybody.
Thank you, everyone.
Thank you, sir.
Good night.
Good night. Thank you.
Thanks.